Hello, this is SkyCushion9, and welcome to Transsistance, a series of videos that talks about many of the topics involved with transitioning, from the point of view of a future medical student and a male-to-female transsexual. Over the course of these videos, I'll help describe the physical, medical, and other aspects about transition, ranging from the anatomy involved, to hormone replacement therapy, to the various surgeries. I hope that with this series of videos I can help educate both transsexuals who are considering transitioning, as well as those who would like to just better educate themselves about an important event and undertaking in the transsexual world. With that, let's get started. Now that I have gone over the male-to-female hormone replacement therapy, it's time to turn our attention towards the opposite side of the road, female-to-male hormone replacement therapy. Now, as a disclaimer, since I am a male-to-female, my knowledge on this side of the hormone replacement therapy may not be as accurate, so I apologize in advance if I mess something up. But with that said, let's begin. To start, let's start with the medications for female-to-male transsexuals, which should actually be stated as just a medication. Female-to-males really only have one drug to take, testosterone. This much simpler regimen is due to two reasons. For one, testosterone is the only hormone produced by the testicles when it comes to the maintenance of the male reproductive system and the development of male secondary sexual characteristics. And two, as stated in the previous video, testosterone holds a dominant role over estrogen and will suppress estrogen whenever the two are present as far as sexual development purposes. Therefore, no anti-estrogen agent is required for successful development of male characteristics. Testosterone can be taken one of four ways: injection, creams, patches, or even pills. However, the first three are typically the methods of choice due to the limited effectivity of the pill form. For injection-type doses, depo-testosterone and dilestriol, are two known options. For creams, androgel is popular, and for patches, androderm is the primary option. Like with male to females, changes as a result of hormone replacement therapy are not immediate. Mental and emotional changes can be noted from 2 weeks on or so. Again, effects typically peak after 2 years or so, with potential further growth a possibility. The most notable emotional shift that a female to male will note is the exact opposite of a male to females, in that the patient would have a better time keeping emotions in check, repressing them, in other words. While the whole unleashing of emotions for male to females and the scaling back for female to males might make things seem like they're just following social stereotypes, it is a shift that many transsexuals note, so it is something to be expected. Female to males, however, also note being more aggressive and direct in both physical and verbal engagements, whereas some male to females will note a greater desire to avoid conflict. As for physical changes, here's a list of general things that a person can look forward to. First, growth of the clitoris. Anatomically speaking, the clitoris is the female anatomical equivalent to the male's penis. The male and female reproductive systems have very many similar analogs due to both systems having developed identically prior to sex differentiation 5 months into pregnancy. As a result, exposure of testosterone will cause the clitoris to grow. However, like breast growth for male to females, the amount of development is usually limited. Growth of about 1 to 3 centimeters is typically noted. Second, increased sex drive. As noted in the previous video, testosterone is the primary hormone responsible for a body's libido. By introducing more testosterone into the body, female to males tend to experience increased sex drive. Female to males also experience a sensation of an erection as well, but this is very limited due to the general lack of corpus spongiosum present in the penis. Third, coarser and oilier skin. Testosterone has the effect of activating more of the sweat and oil glands found in the skin, which obviously leads to oilier skin. This shift also tends to cause acne to develop, which is why acne tends to be far more prevalent in males than females whenever puberty onsets. Fourth, thickening of the vocal cords. Much like the effects of testosterone on the clitoris, testosterone also causes the vocal cords to thicken, which results in a drop in the pitch of the voice, producing a tone very similar, if not identical, to a male's voice. Female to males will often note a cracking in their voice, much like teenage males early in puberty. Fifth, increase in facial and body hair. Testosterone has an activating effect on facial hair and causes better and thicker body hair growth for the rest of the body. As a result, female to males can expect to grow mustaches and beards and exhibit hairier arms and legs. 6. Infertility. Like male to female to males will eventually experience sterility after about 6 months of prolonged dosage. The suppression of estrogen causes the ovaries to weaken and harms the development of the eggs as a result. However, like male to females, there have been cases where female to males far into their transition have become pregnant from sex, and some have even gone as far as delivering the baby themselves. 7th, increased muscle mass and strength. Whereas estrogen tends to focus on the development and redistribution of fat, testosterone tends to focus more on muscle tissue, and many female to males tend to experience some development of muscle tone as well as an increased upper body strength. The only other major beneficial physical change to note is a redistribution of fat from the hips and breasts to the stomach or more male-defined areas. Again, a number of these changes become irreversible after 6 months, but some can be lost if hormones are stopped. And now I shall list the things that will not occur or change as a result of hormone replacement therapy. First, atrophy and loss of the breasts. Testosterone has no effect on breast tissue, much like estrogen cannot affect a genetic male's vocal cords. Developed breast tissue can shrink due to lack of estrogen, but will never go away completely. Second, increased height. Probably the one exception to the build not break principle, a female to male will not become taller due to hormone replacement therapy unless started before puberty, but this is still a possibility of occurring. After puberty has finished, the skeleton ceases any kind of growth of length and structures itself more towards maintenance than anything. Third, development of male-designed skeleton. Like with male to females, female to males will not experience a shrinking of their hip bones or a broadening of their shoulders. Fourth, atrophy and loss of the uterus and ovaries, or the development of penis and male reproductive system. The closest thing a female to male can get to this is the growth of the clitoris, but nothing else. Finally, there are some health risks that a person must be aware of while on hormone replacement therapy. While again the chances of major complications developing are low, one must still be mindful in the event that they do occur. First, increased risk of heart disease and diabetes. It seems slightly ironic that both sides of the transsexual spectrum can experience the same issue, but testosterone does this in a different manner by increasing levels of bad cholesterol, increasing weight gain, and decreasing sensitivity to insulin as a result. Second, increased red blood cell count. While this might not sound bad initially, remember, too much of a good thing can be a bad thing. Female to males will experience this to some degree, but an excessive increase can cause stroke and heart attacks. Third, development of migraines. Self-explanatory, but this is a result of testosterone increases. Fourth, male pattern baldness. As talked about previously, estrogen tends to serve as a deterrent for baldness, which means that a female to male starting hormone replacement therapy will be at greater risk for developing baldness. However, its development depends more upon if it runs in your family or not, either way. Fifth, development of cancers. Female to males are vulnerable to estrogen-sensitive cancers, such as one affecting the ovaries, breasts, and uterine tissue, due to the fact that they're receiving less of them, and, well, this pretty much goes along the same path as prostate cancer does with male to female. Again, other issues can be noted, but I'll leave it at that for now. Before I end my video on hormone effects, I feel I should mention how one can get a hold of hormones, since this is like a critical item to know for those transsexuals desiring to start hormone replacement therapy. The WPATH procedures and guidelines have become a little bit easier nowadays for transsexuals than before, so this may not be necessarily what you will have to go through, but I'll list the processes that I and many transsexuals predating me experienced. First, a patient must find a therapist that deals specifically with either gender dysphoria or gender identity disorder. Transsexualism was recently redefined to the former to eliminate the stigma of it being a mental illness. However, it's important to know both ways of how it is called in the therapeutical world, in the event a therapist isn't aware of one of them. Second, once a therapist is found, the patient will have to go through a few sessions with the therapist in order for him or her to confirm gender dysphoria. Should a therapist feel that the emotions and issues of the patient are legitimate and not a result of coercion or other mental illness, the patient is sent to a psychological examiner to ensure the patient has no current mental illnesses. Third, once validated by the examiner, the therapist finally then refers the patient to a doctor, where the appropriate hormones can be prescribed. Female to males are typically sent to endocrinologists, while male to females are typically sent to OBGYNs, but also have the option of seeing an endocrinologist. And with that, we're all done with the hormonal aspects of transitioning, in a nutshell anyways. So what does this mean with the series? Is it done? Not by a long shot. With the chemical side out of the way, we can start talking about the more physical items involved with transitioning. So with that note, this is Geiger9, this has been Transsistance, and in the next episode, I shall start discussing the manual physical alterations that can be done to aid transitioning, starting with non-surgical techniques. Until then, I'll see you later.